Good afternoon, and thank you for inviting me to speak to the committee today and to be your last formal comments of a very long, very interesting day. I much better recognize the complexity of the task that you have in front of you to put together these recommendations. My name is Heather Pierce. I'm at the Association of American Medical Colleges, and I think it's important to note that as an association that represents institutions, all 147 accredited U.S. medical schools and 17 Canadian medical schools, plus 400 major teaching hospitals and health systems, and 80 academic societies and the VA system. This topic is of importance to all of these institutional members. Unlike Les, I have never personally returned results to anyone, but these hundreds of members have done this, and we've been discussing this for years. It's a complex area that you know from a regulatory, ethical, compliance, medical, and equity perspective. And as an initial statement, the CLIA certification plays an incredibly critical role in the tests used to make decisions about clinical care and in what healthcare providers use to make treatment decisions for individuals. And that is complicated by what's happening or not happening in the research space, where we are talking about a different kind of relationship and a different kind of information. We're also, having listened for the whole day, we're talking about the return of results in a box, as a single topic. But I think it's important that we recognize where it sits in other areas, some of which have been discussed today, but just want to remind the committee some of the related areas. First, this really is in a complicated intersection where we are both trying to clarify the research versus clinical care line while simultaneously advocating and moving towards a learning health system that continually incorporates research results into trying to improve healthcare delivery. That makes this complicated. Second, we can't forget about the atmosphere of continuing to build trust in researchers and research, and that health and healthcare inequities may mean that the return of results doesn't mean the same thing and doesn't have the same impact, or and actionable means something different to different people. The definition of actionable is cloudy at best and may change over time. So if we're talking about returning actionable results, does that mean it is actionable today? If so, then we need to revisit constantly what is actionable and what isn't. Or is there a benefit to returning results that are not actionable and may have no clinical impact today, so that you have them when you're not a research subject 5 years from now, but they become actionable? All of this is over a significantly resource-constrained atmosphere for institutions, for researchers. There's pressure on federal funding. There are challenges to whether the federal government or anyone should provide facilities and administrative costs, which sounds like an ancillary topic. These are costs, funds that are awarded on top of direct costs of a grant, but those facilities and administrative costs are what funds the human subject protection programs, the IRBs, all of the other wraparound services that could create a system of ethical and practical return of results are funded by mechanisms that are in peril. And finally, we have not only here, but all around it, a changing regulatory environment where the changes to the common rule, which will likely go into effect in January, require changes to informed consent and what has to be said about the return of results, discussions about how laboratory developed tests should be regulated, and the like. From my perspective, the primary importance of what you have before you is to ensure that from institution to institution, there's predictable assessment of what results should or may be returned, when they're returned, and how are they supposed to be returned? Under what circumstances and using what method? What should not happen is that this should not be based on the risk tolerance of the institution or how trustworthy the particular investigator seems or the expertise that sits on a specific IRB or who is sitting in the general counsel's office. And that's what's happening today in determining on a subject by a research study by research study, institution by institution perspective on what gets returned and when. The previous panel very clearly laid out the HIPAA-CLIA conundrum. It can summarize as how does an institution decide between you must return and you may not return the information, and overlaid that on that as the ethical imperatives of researchers and institution who at times find it untenable that professionals who have dedicated their career to discovery, improving health, and improving life hold potentially life-changing information and are prohibited from providing that to the individual participant or to anyone who can help that individual participant. In a time when comprehensive health care is not available to all, it is not unusual for individuals who are participating in research to have none or very little other interaction with the healthcare system. Regardless of what we put in an informed consent document, it is not unreasonable for individuals to expect that if their touch to the healthcare system is being part of a research protocol, that if those researchers, many of whom are healthcare providers, have information that could change their life and their health, they will be told. And that remains an expectation even when we tell them that's not the case. So a few, wrapping up, questions and considerations. So assuming clear and unambiguous regulations and guidance from CMS, OCR, FDA, and all of you, it's a small assumption, but I know you can get there. Each institution would have to develop policies, systems, and expertise on both making decisions upfront about what will be returned and then how the results will be returned. So for the upfront decision, we have to think about, should this be all research? And if not, what kind of research should fall into this bucket of what will be returned? Is it all results? This morning on the first panel, someone talked about Fran talked about wanting all 100 data points. Is that a result? Are we returning results, or are we waiting for results that are analyzed and validated? And what is the role of the IRB? This kind of work may require external expertise. That's not something that's an unfamiliar or impossible concept for IRBs, who routinely bring in external expertise to make these kinds of decisions. And what is the process and the technological systems to get these results back to participants? In particular, when biospecimens come from biorepositories, when the study is a double-blind study in which identifying who the participant is may be very difficult, or when there is a very lengthy time from the collection of the biospecimen to the analysis, maybe years sometimes. How do we do that? Returning the results after the fact, to some extent the same concerns remain whether or not the test is done in a CLIA certified lab. We shouldn't equate CLIA certified to mean that the test has proven clinical validity, and that's something that I think is important and has been reiterated through this panel, that there are certain safeguards around the test, but it doesn't necessarily mean that we know what the test means. We should not assume that researchers will know and be able to effectively communicate and appropriately explain the clinical consequences of such a result. So we may need intermediaries, like a primary physician or other healthcare provider, genetic counselors, or others who receive the information and then can either make a decision to further validate through a CLIA certified lab or others. This all requires resources. Researchers and institutions need guidance, they need training, they need systems. Return of result is not currently routinely written into grants. The answer isn't always CLIA certification, and that won't answer all of the questions. Thank you, and we look forward to the discussion.